Hello everyone, this is Dr. Arif from the 7th Affiliated Hospital of Sun Yat-sen University, China. I'm also working as a section editor of Health Interactions, associate editor of Clinical Case Reports, associate editor of Medical Reports, and assistant editor of Journal of Orthopedics. Today I will talk about a very important issue in medical education, how to bridge the gap between theory and practice in MBBS program, with the example from Bangladesh and China. Around the world, MBBS students feel unprepared when they first deal with the real patients. They know the theory, but when it comes to clinical work, they lack of confidence, clinical judgment, and basic skills. This gap between theory and practice can affect the patient's safety and students' development. So, fixing this gap is not an option, it's necessary. In Bangladesh, MBBS follows the BMDC curriculums. From the third year, students join the hospital for clinical rotation. And in the final year, they complete 1 year internship. The good thing is they see many patients earlier. That gives them valuable real world experience. The teaching in hospital is mostly through bedside learning, mini lecture, and community visit. But there are challenges too, like a big students group, not enough simulation tools, and limited faculty training. So the exposure is good, but the structure and supports are still developing. In China, MBBS is more structured. The first 2 years are for theory, third and fourth years on clinical subjects. In the final year, students do internship. After graduation, they also can join GUIPE, which likes residency training. It's a step-by-step learning model. In China, students learn from the top teaching levels hospital. They also get practice in simulation labs before seeing the real patients. Many universities require students to know basic Mandarin to communicate with patients. Assessments are done using tools like Mini CEX, OSCE, and logbooks. In Bangladesh, exams are more traditional, like Viva and long cases with real patients. In China, there are more use of OSCE, Mini CEX, and simulation-based exams. Both systems are useful. In Bangladesh, exams are more traditional, Viva and long cases with real patients. But in China, there are more use of OSCE, Mini CEX, and simulation-based exams. Both systems are useful. One gives real-life practice, and other gives structure and feedback. Here is a summary. Bangladesh has more exposure to patients. China focus on simulation and stepwise learning. The ideal model would be a mix of both. Real patients contact with structured support and assessment. China and Bangladesh collaboration. There are already many positive joint initiatives. Students and faculty exchange, online clinical teaching, joint workshop and training, even research on AI-assisted diagnosis. These effects both countries improve and learn from each other. What we can do to improve MBBS education? Use competency-based learning, plan a structured clinical rotation, start patient contact earlier, use simulation and clinical cases, give regular feedback. These strategies are working in many countries but can help in China and Bangladesh. To make all this possible, we need support from universities and hospitals. Bangladesh is starting to invest in skills lab. China balanced structured training in with mentorship. Both countries they should to make all this possible. We need support from universities and hospitals. Bangladesh is starting to invest in skills lab. China balanced structured training with mentorship. Both countries should support and train clinicians, teachers, because they are key to success. More bilateral programs can help both systems grow stronger together. In summary, bridging theory and practice is essential to produce safe and confident doctors. Bangladesh gives strong clinical exposure. China offers structured and simulations. The best system combines both hands-on learning with structured supervision. Let's work together to create better medical education through partnership and reforms. These ideas are supported by recent studies. Articles from BMC Medical Education and PubMed shows that combining simulation with early clinical practice leads to better outcomes. Research from Asia confirms that structured clinical teaching improves skill and confidence. Thank you very much for listening. I truly believe that collaboration between countries, between universities and hospitals can bring a big change. I welcome your suggestions and ideas.